Hello, everybody. I'm hoping all of you are doing healthy and fine during this time of the pandemic, as we've been restricted from not reaching our workplaces. This will be the mode of communication as well as for taking this lecture for today. So today's topic of discussion would be on endodontic irrigans. I'll be covering endodontic irrigans under the following headings. Firstly, as you're all aware, when a tooth is indicated for a root canal treatment, that is when the tooth is infected or when there's a periapical change and when there is deep dentinal caries, which might lead to an irreversible pulpitis. Such cases are referred for an endodontic treatment. As you're all aware, an endodontic treatment starts with the access cavity, following by estimation of the working length of the tooth and the mechanical shaping of the tooth, followed by irrigation or cleaning within the tooth and obturation, followed by a co-buildup. So how important is it to do a final irrigation or a final disinfection within the tooth? As we are all aware, during mechanical instrumentation, there are still many areas within the tooth where the files they fail to reach or touch. So in such cases, the only way that we can access inside such areas is only through a mode of irrigation or disinfection. Moreover, the apical anatomy of a tooth, or even the internal anatomy, not just the apical anatomy, or even the internal anatomy of the tooth, is so complex that there are many areas that will be left uninstrumented, like I mentioned earlier, such as in case of an accessory canal, a lateral canal, then an apical delta. All these areas may be missed out during instrumentation. So to irrigate, so to cleanse these areas or to remove the mechanical debris or disinfect these areas, we primarily need to rely on our irrigation protocol. Moreover, the other functions of an irrigant is primarily to flush out the necrotic pulp or the vital pulp or the disease pulp that is present within the canal system. Secondly, it is to remove the debris that's been accumulated because of the mechanical preparation which is brought about. And thirdly is to break the biofilms or the break the biofilms within the canal system as well as to disinfect the canal system and to permit a good endodontic healing. Like I mentioned earlier, there are always areas within the canal system that remains uninstrumented. For example, in the first diagram, we can see a narrow isthmus which is connecting the two major foramina. It is very difficult to instrument the isthmus areas. So in anatomical cases, anatomical variations like this, we really need to rely on irrigation. Similarly, you can see in the second diagram where and there's an apical delta that is formed. So there are five minor openings, which is found around the major foramen. So to cleanse, to mechanically debride this area is not possible via instrumentation. So in such cases, again, we rely completely on irrigation. This is again like the isthmus area with the connection that I mentioned earlier, where mechanical debridement itself will not be enough. According to the definition of endodontic irrigants are nothing but liquids or solutions that are widely used during the cleaning and shaping to dislodge debris from the root canal system. They are subjected to have an ideal property, which means they should be rapid, which means they should be able to have a very quick action, They must be biocompatible. They need to be economical. They should not cause any harm to the periapical region. They should always stimulate repair and healing. It should always lessen the pain and should have an ability to diffuse and penetrate into the dentine. It should not discolor the tooth as well. It should not lead to discoloration of any form as well, and they should be easily be available. Okay, these are the uh, few properties or the ideal properties which an irrigant should be possessed with. Now, moving on to the classification. So, if it's if it's for writing a answer for your exam, so classification is always important. So, whether according to a classification as well as a definition is always important. So, classification of irrigants, there are many classifications that have come across, but just to mention few of them, I have taken. So classification of irrigants is mostly as given by Tagore would be a working solution and an irrigating solution. A working solution would be something which would have a very specific property, or it would be very specific. Its mode of action would be very specific. Whereas a normal irrigating solution is nothing but to flush out the mechanical debris that is present within the canal during the instrumentation. An irrigating solution, an example of an irrigating solution would be saline. Whereas in case of a working solution, it could be, like I said, it is a very specific, it will have a very specific function or action. So that would be, for the examples for that would be something like sodium hypochlorite, which is a tissue dissolution. A chelation agent would be EDTA. Then the other classification, which was given by Stock, is chemically inactive and chemically active. In case of chemically inactive, like I mentioned, it would be water and saline, which is primarily used for only mechanically debriding. Whereas a chemically active solution could be an acid, could be a chelator, it could be an oxidizer, it could be detergents, or it can even be an alkali. So they again also have specific actions. And there is something related to the hydrodynamics of an irrigant. The hydrodynamics of an irrigant, it primarily depends on the penetration depth of the needle, the diameter of the root canal, the inner and outer diameter of the needle, the irrigation pressure, the type and orientation of the bevel of the needle as well. Moving on to our first irrigant, which is most commonly used and seen everywhere, is the physiologic saline. Saline, it's more of a, like I mentioned earlier, it does not have a specific action. It does not have an antibacterial property, nor does it have any property to dissolve necrotic pulp tissue. It's primarily used to remove the mechanical debris that has been created during mechanical instrumentation. The advantages of physiological saline is that it causes least damage to the apical tissue. It is highly biocompatible and it does not cause any amount of cell lysis. The disadvantage is that it does not remove the smear layer and it does not, like I mentioned earlier, it does not have any antibacterial property. Sodium hypochlorite, which is one of the most oldest irrigants that has been used, it was first recommended by Henry Dakin in 1915 and it was known as the Dakin solution during the time of World War II. Sodium hypochlorite, that is 0.5% buffer sodium bicarbonate, was used for treatment of infected wounds. It's available in various concentration. And it starts from 0.5% to 1% to 2.5%, 3% and 5.25%. It is commercially available as a household bleach and was first recommended by Lewis and has gained wide acceptance as a commercially available household bleach. It's always been the irrigant of choice. It has a very effective antimicrobial agent. It has an excellent organic tissue. It's an excellent organic tissue solvent, which means that it has the ability to dissolve the necrotic pulp tissue. It has a lubricating action and it has a very quick action as well. And sodium hypochlorite is known for its antimicrobial action. Studies have generally shown that sodium hypochlorite has a broad spectrum of antibacterial activity. It can rapidly kill vegetative bacteria, spore-forming bacteria, fungi, viruses, and bacterial spores, like I mentioned earlier. Manufacturing, it is commonly manufactured by two methods. That is where the first method is where chlorine and sodium hydroxide is added together to give sodium hypochlorite, and the second method is basically by the electrolysis of saturated brine solution to produce sodium and the mechanism of action is that when sodium hypochlorite comes in contact with the organic debris. The organic debris could be vital pulp tissue, it could be necrotic pulp tissue, or it could be even necrotic pulp tissue. It forms hypochlorous acid. Hypochlorous acid is the one that penetrates the bacterial cell, oxidizes the sulfidyl groups of the bacterial enzymes, and this disrupts the metabolism of the bacteria, which eventually leads to the cell death. Sodium hypochlorite has a high pH as well of 11 to 11.5, which is effective in eliminating anaerobes which need an acidic environment to thrive. Potent tissue solvent property. The solvent action of hypochlorite has been attributed to its high alkalinity. Grossman and Maven reported that 5% hypochlorite dissolves pulp tissue in 20 minutes to 2 hours. There are various methods that can be used or practiced to increase the efficacy of hypochlorite. That would be starting from lowering the pH, increasing the temperature, using an ultrasonic activation, like I mentioned earlier, increasing the volume as well as the time of irrigation can also enhance the efficacy of sodium hypochlorite. Moving on, increasing the temperature. According to Baltimore, the capacity of 1% hypochlorite at 45 degrees to dissolve the human dental pulp was found to be equal to that of 5 to 25% solution at 20 degrees Celsius. Clinically, warming sodium hypochlorite is done in a water bath at 60 degrees Celsius. The effect of temperature on sodium hypochlorite is short-term stability. Pulp dissolution capacity and microbial efficacy is more. Volume, like I mentioned, is considered to be very critical. That is, if the concentration we are using is lesser, then a higher amount of irrigant should be used. This is a diagram which was taken from Castellucci, which is an extubated pulp. The second image shows what happens when it's immediately placed into hypochlorite, 5.25% hypochlorite. And the third image shows that after 5 minutes, the pulp tissue actually dissolves. It's almost a partially dissolved. Whereas in the last image, you can appreciate that there is no more of the necrotic pulp. This was placed in 5.25% concentration of sodium hypochlorite. The disadvantages of sodium hypochlorite is that toxic if not used properly. It is ineffective at lower concentration if it's not used in a higher volume. Then it is not substantive, which means it is available only at the point of irrigation, and after that, once it's cleared off, there won't be any action. It discolors, like I mentioned, if it falls on the patient's clothes or even as well as on the dentist, it can tend to bleach the clothes. It can corrode our instruments, especially the file that we use and our hand instruments. Moreover, it has a very unpleasant odor. Accidents are also another problems that or another difficulty that we encounter during our clinical practice. It is nothing but the inadvertent injection of sodium hypochlorite into the soft tissue, which can elicit a violent and a frightening response. Like we mentioned earlier, sodium hypochlorite itself is a tissue dissolving agent. So a hypochlorite accident is very similar to angioneurotic edema with release of histamine or histamine-like substance, which can cause a vasodilation with subsequent transudation of plasma accompanied by hemorrhage. The sequence of events is that obviously there is excruciating amount of pain that the patient encounters. The patient tends to jump up, they generally have a tendency to jump up from the chair when the irrigating solution can go beyond the periapical foramen, or when the irrigant is forced beyond the periapical foramen. There's a burning sensation in the affected area. There is immediate swelling of the tissue in the area which spread to the surrounding loose connective tissue. There's profuse bleeding episode either interstitially or through the root canal system. The interstitial hemorrhage may result in ecchymosis over the skin, because of which the affected skin might be discolored. This happens over a period of few hours, the discoloration of the skin. But the remaining symptoms are most commonly seen immediately uh, after it is extirpated, it's not extirpated, sorry, after it goes beyond the periapical foramen. The treatment modality would be to actually stop the treatment that you are giving to the patient. Make sure you reassure the patient. Make sure you also, as the practicing dentist, remain calm. There is no antidote as per se. What we can immediately do is irrigate that area with copious amount of saline so that the area of hypochlorite in the specific area is diluted. Then evacuate the airway. There will be for pain control. Administer anesthesia, or even giving a nerve block would be required. Prescribe analgesics to the patient. Corticosteroids can also be administered to avoid the swelling. Antibiotics only if absolutely necessary. The patient must be instructed to give to be must be instructed to do a cold compress for the first 6 hours or the first 24 hours, followed by a warm compress and mouth rinse for a week. Provide verbal and written home care and always inform the patient what had happened. Make sure you do a regular follow-up starting from 2 days, 4 days, a week, and a month. There are certain ways where you can prevent the sodium hypochlorite accidents. What we can do to prevent such accident would be adequate access preparation to facilitate a better access. Your working length should be absolutely correct, or a good working length control. Irrigation needle should be placed 1 mm to 3 mm short of the working length so that there is no extrusion of the irrigant. Flowback of solution as it is expressed into the canal should be observed. Constant in and out movements of the irrigating needle into the canal space to be done to ensure that the tip is free to express irrigant without resistance. In case any resistance is felt, irrigation needs to be stopped immediately. Use of side delivery needles that are specifically designed for endodontic purpose as advocated. The hub of the needle should be checked for a tight fit to prevent inadvertent separation and accidental exposure of the irrigant to the patient's eye. Moving on to our next irrigant, which is chlorhexidine. Chlorhexidine, which is a cationic bisgranide, and it has a pH of 5.5 to 7, is also under commonly used in case of our endodontic irrigants. The mechanism of action of chlorhexidine is that it's able to absorb the surface of the bacteria due to the cationic and anionic electrostatic attraction. Once it adsorbs to the surface of the bacteria, it makes the cell membrane permeable. Once the cell membrane is permeable, this results in the micro leakage of the intracellular components immediately, leading to the cell death of the bacterial. Moreover, the most important property of chlorhexidine is the substantivity. Clinically, chlorhexidine substantivity seems to be another advantage over hypochlorite, sustaining the antimicrobial property over a period of 48 hours or 72 hours after treatment. Their cationic properties also allow them to bind electrostatically to surface. This helps them to gradually be released from the surfaces as the concentration of chlorhexidine in the environment decreases. So the important property of chlorhexidine is the substantivity. And unlike hypochlorite, chlorhexidine, it does not have a bad odor. It is not equally irritating to the periapical tissue. It does not cause spot bleaching of patients' and doctors' clothes. It has no deleterious effects on the physical properties of dentin. Concentration. Commercially available chlorhexidine, especially the mouth rinses, have a concentration of 0.12%, but for an endodontic purpose, we should always use a chlorhexidine concentration of 2%. They are available as both liquid and gel formulations. The primary indications of chlorhexidine, it could be that it is primarily used in teeth with open apices. So there is no fear of extrusion. Even if there is a certain amount of chlorhexidine that is extruded, it does not cause as much as excruciating pain or discomfort to the patient as much as hypochlorite. Similarly, in case of perforation, there are high risk of displacing the irrigation into the periapical tissue. Then, in case of patients who are allergic to sodium hypochlorite and primarily used in retreatment, it's primarily used in retreatment cases. One of the most oldest irrigants which is still being commonly used is the iodine potassium iodide or the IPI irrigant. It is used in a concentration of 5 to 10% and it is very potent and has a antimicrobial property against bacteria, virus, fungi, and even spores. It is less cytotoxic and irritating to vital tissue than sodium hypochlorite and chlorhexidine. It has considerable antimicrobial activity but no tissue dissolving capability. It can be used at the end of chemomechanical preparation like chlorhexidine, but some patients might be allergic, so that needs to be taken into. Smear layer and its importance. As you might have all heard of what a smear layer is, a smear layer is basically a thin layer that mostly occludes the dentinal tubules and covers the intertemporal dentine of the prepared canal wall. The smear layer is primarily composed of debris that are made up of very small particles of mineralized collagen matrix. So if there is a smear layer present within the canal system, what happens is that there would be ineffective disinfection of the canal system. Why? Because the irrigants that we use for disinfection, such it could be sodium hypochlorite, it could be chlorhexidine, or even IPI irrigant, it will fail to absorb or it will fail to go through the interdentinal tubules to disinfect each tubule or the canal system, because the smear layer will block it from diffusion. So the smear layer needs to be always needs to be removed. Moreover, in between the intertubular dentine or spaces present, there are tendencies for bacteria or microbial flora to be lodged in these canal systems. So all these can be removed only via irrigation, followed by before removal of the smear layer. According to Lester and Boyd, is nothing but organic matter which is trapped within the translocated dentine. So what happens is that, like I mentioned, it acts as a substrate for bacteria, allowing the deeper penetration into the dentinal tubules. And why it needs to be removed is that it prevents the penetration of irrigants, medication, the filling material into the dentinal tubules and even impede their contact with the canals. So the effect of individual irrigant upon smear layer removal. Sodium hypochlorite, EDTA. Sodium hypochlorite, that is 5.25% of hypochlorite can be used, but that removes only the organic part of the smear layer. The inorganic part still remains. So EDTA removes the smear layer on dentine, resulting in better contact surface between the canal filling, the dentinal wall, and better penetration of sealer within the dentinal tubules. The other smear layer removal agents that can be used are citric acid. That is 50% citric acid gives cleanest dentinal tubules without smear layer. Chlorhexidine has not been proved to be effective for the removal of smear layer. MTAD, that is sodium hypochlorite followed by MTAD solution, when used as a final rinse, completely removes the smear layer. Lasers can also be used to remove it. Like we mentioned about smear layer and its removal, there are certain chelating agents such as EDTA. EDTA is nothing but ethylene diamine tetraacetic acid, which has been introduced by Nigard Osby in the year 1957. It is an insoluble, odorless, crystalline white powder and is relatively non-toxic and slightly irritating in weaker solution. It does have a pH of 8.3. The disodium salt of EDTA is the usual form employed in dentistry and is adequately buffered to 10 to 15%. The most common concentration of EDTA used is 17%. Like I mentioned earlier, properties of EDTA is that it has a smear layer removal, it has dentine dissolving effects, which is desirable in all kinds of root canal therapy. It can be used in case of calcified canals. It can because it aids in enlarging narrow or the obstructed canals. It also helps in bypassing fragmented instruments. It is not corrosive on instrument. Antimicrobial, that is, it is not bactericidal nor bacteriostatic. EDTA has a self-limiting action, which means that the optimal working time for EDTA is 15 minutes, after which it will stop chelating, or the chelating action cannot be expected. So we need to always replenish the canal system with a new amount of EDTA. So according to recent studies, it has been modified to even 10 minutes. These are certain images or the SEM images where you can see that the dentinal tubules have been exposed. And it's very clear, which means the smear layer has been removed and the tubules are open and the canal is clean and free of the. This is the same image when the smear layer was not removed. So this is when there was water, when it was treated, following by NaOCl 5.25%. A characteristic appearance in an SEM study is called the wormhole. There are various chelator preparations. These are given in our textbooks, so you can read in detail about them in our textbooks as well. These are just a few names that I've mentioned. The most common chelator paste that we use is the RC prep. RC prep, but it has a composition of 15% EDTA, 10% urea peroxide as a glycol base. The main function is that it softens the dentines and facilitates the instrument movement. Moreover, RC prep is insoluble in water. Interaction of the urea peroxide in RC prep with sodium hypochlorite produces a bubbling action which loosens and helps float out the dentinal debris as well as the necrotic pulp. The various other organic acids used as an endodontic irrigant are the tannic acid, malic acid, and citric acid. Tannic acid can be used in a 25% concentration. It is used as a cleansing agent. It has astringent properties. It also possesses antimicrobial properties. Malic acid is a mild organic acid. It can be used as an acid conditioner, primarily used as an acid conditioner in adhesive dentistry. and better smear layer removal. Various interactions that we need to consider is between irrigants in case of NaCl and EDTA. They enhance considerably the bactericidal effect. Chlorhexidine and NaOCl in together should not be used as they are not soluble with each other, and a brownish orange precipitate is formed which when they are mixed and they precipitate prevents the clinical use of the mixture. This brownish orange precipitate that is formed is nothing but parachloroanilins, and they are said to be toxic and they are carcinogenic as well. Combination of chlorhexidine and EDTA also should not be used together because they tend to form a white precipitate. They tend to form a white precipitate. Combination of sodium hypochlorite and hydrogen peroxide, even though they've been used together, the effectiveness has not been shown to be better than that of sodium hypochlorite alone. So every time we are using multiple irrigants within a root canal system, every time you introduce a new irrigant, say you have used after your mechanical preparation, where you have extirpated the pulp and enlarged the canal system, you always need to intermittently flush it with saline. If you have removed the smear layer using EDTA, after the EDTA rinse, you need to always flush the canal with saline, following which you can use a disinfectant irrigant, which can be hypochlorite, or chlorhexidine or any other disinfectant irrigant. But never introduce two irrigants at the same time within the canal. Every time a new irrigant is introduced, always make sure you flush it out with saline. BDA is nothing but bisdiqualenimine acetate. It is primarily used as an excellent substitute for sodium hypochlorite to those patients who are allergic to it. It has a low surface tension chelating properties, and it's shown to have a very low incidence of post-treatment pain. MTAD is a mixture of tetracycline isomer, acid, and detergent. It has an antibacterial activity and it has a low pH of 2.5. MTAD, it is contraindicated in case of pregnant and nursing mothers as it can have a systemic effect to discolor the developing teeth. Some other irrigating solution that you need to be introduced is in the case of ozonated water. Ozonated water is a powerful antimicrobial agent against bacteria, fungi, protozoa, and viruses. It has the ozone has the ability to destroy cell walls and cytoplasmic membranes of bacteria and fungi. It increases the permeability. It increases the permeability, which leads to ingress of ozone, which causes the microbial death. The advantages is that it has a very high potency. It is easy handling. It has rapid microbial effects, and it has been shown to have lesser cytotoxicity. The major disadvantage would be is that it's not economic, and rapid ozone degradation occur in presence of the organic compounds. Ruddle solution. Ruddle solution has a composition of 5% sodium hypochlorite, Hypic M, which is nothing but iodine salt, 17% EDTA, and the pH between 6.5 to 7.7. It has been previously used in several applications such as arteriography, venography, and uterography in the medical field. It is primarily used to study the canal system under an endoscopy. So Ruddle solution, because of its radio opacity, because of the presence of high peak, it has like I mentioned, it's used primarily to visualize the microanatomy, verify the shape, monitor, and the remaining root wall thickness. Johnson-Callahan method. It's quite an old method, but it is not used at all these days because of frequent complication and there's a high potential for necrosis. It consists of 20% sulfuric acid and saturated solution of bicarbonate of soda. 20% sulfuric acid and saturated solution of bicarbonate of soda. Here we'll be discussing the various techniques used to irrigate the canal chamber. More than the quality of the irrigant that we use, it's primarily how we agitate or mechanically agitate the irrigant which is more important. Some of the techniques which we still follow are the Somers technique. Somers technique is nothing but you place a few drops of irrigant in the pulp chamber. You create a whirlpool effect with the help of a small fire. So once the access is done, you flood the chamber with the irrigant. It's very similar to the Grossman's technique. But in Grossman's technique, what they say is that once the chamber is devoid of the irrigant, you need to replenish it again. Syringes, the most common mode of irrigation is by the use of syringes. Syringes are mostly plastic syringes of different sizes that are available. There are large volume syringes as well as there are smaller volume syringes. Large volume syringes potentially save more time, but they are difficult to control for pressure and accidents may happen. Therefore, to maximize safety and control, use of 1 to 5 ml syringes is highly recommended. All syringes for endodontic irrigation must have a Learlock design. Syringe, when we talk about syringes, what is need to be kept in mind is the needle or the gauge of the needle. Gauge of the needle is nothing but the thickness. So the gauges range from 22 gauge to a finer 30 gauge, and even 31 gauges are available. So what you must remember is that if the size of the gauge increases, say if the gauge of the syringe is or the needle is 30, which means it will be thinner. Since irrigation of the apical third requires the needle to be in its proximity for adequate effect, studies have been conducted that canals should be flushed with a 27 to 30 gauge needle placed in the apical third. The method of use in case of a syringe or the needle should be that the needle should always lie passively, which means it should not bind to the canal walls, bind or engage to the canal walls, and the solution must be introduced very slowly. The needle should always be bent at an obtuse angle to allow for easier access and entry to the orifice, and the bend is always placed closer to the hub of the syringe, so that in case if there is a separation of the needle, it is easily retrieved. And care must be taken with irrigants such as hypochlorite to prevent accidents. Like I mentioned, the angulation of the bend should be an obtuse degree. Moreover, a rubber stopper should be placed to approximate the working length. Then the obtuse angle or the bend should be always placed closer to the hub of the needle, and always use the forefinger to depress the plunger, which gives a greater control of the irrigant delivery. Squeezing with the thumb may result in a more rapid delivery of the irrigant and possible extrusion of the irrigant. There are various designs of the needle. It can be an open-ended blunt needle. It can be a bevel needle, which is the one we commonly use. The blunt-ended side-venting needle, the Florence, the notch tip, that's the monojet, and perforated needle. The bevel needle, like what we normally use or what we are exposed to normally in our college or clinics, is where you can see the irrigant is forced apically, and in such cases, in case of bevel needle, there is a risk of extrusion of the irrigant. Monojet tip or irrigants can always pass sideways, and a safe-ended tip where the irrigant passes sideways. Pro-rinse, it has a closed end and has a side wound. So it eliminates the possibility of the puncture of the apical foramen. An expression of fluid through the lumen creates turbulence around and beyond the end of the probe. Recent advances is such as the Stopco irrigator system, which combines the delivery and recovery of the irrigant in one probe. Endoactivator relies on sonic vibration. So an activator is it's a new type of irrigation facilitator. So like I mentioned, it relies on sonic vibration, which is up to about 10,000 CPM of a plastic tip in the root canal. And the system has three different sizes of tips that are easily attached or snapped on to the handpiece that will create the sonic vibration. It does not deliver a new irrigant to the canal, but it facilitates the penetration and renewal of the irrigant in the canal. You can see the endoactivator with the plastic tip, and in the second image, which is the image B, you can see it in sonic motion, which means it vibrates in a transverse motion. This vibration or the sonic motion helps to agitate the irrigant which is placed within the canal and thereby increasing the efficacy of the irrigant. Vibrant. Vibrant is also a new sonic irrigation system. It combines a battery-driven vibration with a manually operated irrigation of the root canal. Vibrant uses the traditional type of syringe or needle delivery but adds the sonic vibration. Rinse Endo is based on a pressure suction mechanism with approximately 100 cycles per minute. The rinse endo handpiece delivers irrigation solution right to the apex even in unfavorable conditions. Endovac is again a facilitator where a negative pressure approach whereby the irrigant is placed in the pulp chamber and is sucked down the root canal and back up again through a thin needle with a special design. So in this, the first diagram, you can appreciate where it is basically the system which introduces the irrigant, and whereas the second system is which sucks the irrigant down up to the root canal and helps in removing it through a thin needle with a special design, which is the endovac. So it basically works on the negative pressure approach. Photoactivated disinfection. It is a fast, effective, and minimally invasive disinfection system which is considered to kill more than 99% bacteria in the endodontic biofilm. The mechanism of photoactivated disinfection is that a low-powered laser light is transmitted through the disposable fiber optic tip to activate the photoactivated disinfection solution. So these photosensitizer molecules, they attach to the membrane of the bacteria. When there is an irradiation of light at a specific wavelength which is matched to the peak absorption of the photosensitizer, there is a release of singlet oxygen which causes the bacterial cell wall to rupture, killing the bacteria. The advantages is that it is very effective against antimicrobial agent. It can effectively kill both gram-negative, gram-positive, aerobic and anaerobic bacteria. It can overcome the problem of antibiotic resistance. It can kill bacteria present in complex biofilm, which is typically resistant to action of antimicrobial agents. It does not possess any thermal risk due to low power of the photoactivated disinfectant laser, nor are they toxic to the patients. Ultrasonic irrigation, which was first introduced in endodontics by Richmond, Martin and Cunningham have coined the term endosonics. Martin was the first to design the first commercial system which used ultrasonics for preparing root canal. And these are very similar to the sonic vibration, but they have a higher frequency. They rely on a much higher frequency of 25,000 to 30,000 kilohertz, hence the name ultrasonic. So these files operate in a transverse vibration, which means a right and left vibration, setting up a characteristic pattern of nodes and antinodes along their length. It has been shown that the ultrasonically driven files are effective for irrigation of root canals. And there are two types of ultrasonic irrigation that have been described in the literature. One is where the irrigation is combined with simultaneous ultrasonic instrumentation, and the one without simultaneous instrumentation, so-called passive ultrasonic irrigation. Some few terms that you need to be familiar while using ultrasonic irrigation is the acoustic streaming. Acoustic streaming is basically the rapid movement of fluid in a circular or a vortex-like motion around a vibrating object. So the acoustic streaming that occurs in the root canal during ultrasonic irrigation has been described as acoustic microstreaming. The shear flow caused by acoustic microstreaming produces shear stresses along the root canal, which obviously involves the removal of the debris and bacteria from the wall. Cavitation is again a principle where creation of new bubbles or the expansion or contraction or distortion of the pre-existing bubbles in a liquid. So this cavitation also process and are being coupled to an acoustic energy. So when these bubbles expand, they rapidly collapse, producing a focus of energy. So in an ultrasonic irrigation, cavitation of these bubbles, they also contribute to the deterioration of the microorganism. Application of irrigant during passive ultrasonic irrigation, which means a continuous flush of irrigant from the ultrasonic handpiece or an intermittent flush method using the syringe delivery. In case, like I mentioned earlier, the most important factor is the delivery system and not the irrigation solution per se. The volume of irrigant is more important than the concentration or the type of irrigant. So the way you deliver the irrigating solution into the canal plays a minor role more than the irrigant itself. And the other most important factor that you need to remember in case of irrigation is that every time you introduce a new irrigant, make sure there is intermittent flushes with saline. No two irrigants should be mixed in the canal chamber. Since saline is a neutral irrigating solution, it does not interfere or react with any of the other irrigants. Many new materials have Many new materials and methods have been introduced to improve the root canal debridement and to achieve root canal sterilization. In the age of evidence-based dentistry, it is advisable to wait until quality independent data are available to support the use of such new technology. So I'd like to conclude that instrumentation of the root canal system must always be supported by an irrigation system capable of removing pulp tissue remnants and dentinal debris. A variety of chemical agents in fluid form and sometimes in viscous preparation have been used to aid canal preparation and irrigation. Ongoing researches are directed towards comparing the different irrigating solution and different methods of irrigation to enhance the cleanliness of the root canal preparation. These are the text differences. Thank you. Thank you all for your patient listening.